And I was just trying to think about. Can you see in it well enough on that screen, or do you want to go onto your other screen?
Huh. I think I can see well enough, but if not, I don't even know what time it is. Oh, it's 12:39. Let me see if I can switch over to this one. I might just be audio.
Yeah, that's all right.
Are you able to hear me now?
Yeah.
Oh, wow.
You could probably do, but oh no, that would be too complicated. But I can hear you loud and clear.
Then in that case, you get to have the fortune of not seeing my antics on my face, and you can share this. Oh, I got to give you access to this.
Yeah.
There we go.
All right, let's go. Share screen. Let's share that one. Right. Let's have a look. You have to bear with me. Just while you were talking, I found, just while we were chatting, I was having a look for injections where I perhaps didn't see the needle as well as I might. Okay, so I'm there. I'm not quite seeing it as well as I should. I can just see the tip there.
Uh-oh, do you think you're showing me something?
Yeah, sorry. Oh, right. Helps if I hit the right button. So are we up and running?
Yes, we are. Now I have it very well.
So I was trying to think of show an example where I don't see the needle very well. So I found this one. And so the needle's coming in here. And I'm seeing it go through. And I'm looking for this to put fluid into that plane there. So I'm now bending the probe around a little bit, just so I can just see the tip. Yeah.
And let me see if I can understand this. You recognize that your angle is so obtuse, or not. Your angle on the needle is not going to give you clear refinement.
It's not giving me as good a picture as I like there.
And that's why you're attempting to ultimately bring the probe around to give you a little bit more reflection.
Yeah. Well, as you can see there, I'm quite happy that I can see the needle there coming down through the picture.
Are you able to point with your where the needle is?
There's the tip of the needle there.
Okay.
If I bring the video back a little bit and then run it, you'll see. So it's coming in down there, and there's the needle, and there it's just gone through to here. Now I can't see it now, so it's dropped out of my picture again because I'm not scanning it accurately enough. And there I can just about see the needle there, and then I put some fluid in. Yeah.
Is this trochanteric bursa, or is this?
Yes. Yeah, that's trochanteric bursa, and so that's quite a deep. It's.
Hey, John, a little affirmation that I knew where I was. Now and then wouldn't be
cool.
bad.
That was good. Yeah.
I'm giving you a rough time.
But you see, I'm working my way around. I can just about make out the tip of the needle. That I would consider about the limit. I would expect to see the needle better than that most of the time.
You feel, however, that it is certainly clinically responsible. I mean, you were able to get there. You knew where it was. You just used the markers and you delivered the product, and then you were done. It does not, just because you did not refine the entire needle, I don't believe, at least in my mind, doesn't mean that there was a subpar delivery.
No, that was in the right spot.
Yeah.
And I can see the tip of the needle. And I'm, I do an awful lot of these, and if I really need to see the needle better, I would just, if there was any risk involved, I would use a much longer needle, and therefore come in much more parallel.
That was beautiful.
But that's a straightforward one, and I'm controlling because I know where I am in the body, and I know the angle the needle's got to go in to get to where it's going to. Then that is a perfectly safe and reasonable way to do it.
But what I think I heard,
complicated.
I'm
Yeah.
sorry. What I think I heard you say was that this level of resolution to the needle represents the worst of what you have to offer. This is your effort of saying this is the worst case imaging that you're exposed to. The rest, it's not rare that, I mean, on a given day, 90% of your injections, you're seeing 90% of the needle.
Well, you should always be trying to see the tip of the needle. You know, I sometimes not worry too much about the base of the needle, but you need to know where the tip is, and you need to reliably check where the tip is, and you need to check that your probe's in the right place and everything. But yes, this isn't. I doubt if this is the worst injection I ever did, but it is, in terms of imaging, I would expect to get that for any injection. I would expect to get better, essentially better than that, in terms of actual visualization of the needle. I'm absolutely sure where the tip of that needle is, even before I put anything in. But you should and can get that sort of quality picture, at least.
Well, let me ask you this. I have heard instructors of interventional imaging to refer to the out of plane technique that has a person walking the needle down to the point where you need to be by watching the trajectory and doing that. Do you ever use that? And is that like, do you have any examples of that type of thing?
Yeah. Just if we just look for CMC injection. So you'll see if quite a few of those. Let's see, joint injection out of plane. Let me go back here. So this is the first CMC joint, and there's the needle coming in. Just the point of it there.
Yeah.
And then I think I'm going in too shallow, so I'm try changing the angle. And at some stage now, I might take hold of this. There it is. So I'm dropping it down into the joint, so I can see the tip there in the joint. Yeah.
I see that perfectly.
And then I fill it up, and you see the juice go into the right spot. So that's first CMC. Let me just have a quick check. Just see if I can find a more recent one. Let's have a look at this one. So this will be the same one. I modified my technique. So you should see me do what I do. So I've put the needle in the right place. Then I take the probe off and I turn it round. And then I show the needle inside the capsule in long section. So that's the technique I use now. Yeah.
You're amazing, John.
So I find so you basically for the small joints that are really tricky to get into if you go in plane, either because of the shape, usually because of the shape of the joint, or they're particularly superficial. It is easier to pop them in out of plane. But for most of them, because these are generally small joints, it's actually quite easy to get that, even though you see the needle in the joint, because they're often quite small joints. When you come into the long section, if you see where my needle tip is there, sometimes the needle tips actually come out the other side of the joint.
Ooh.
Because you've gone into it, so you see that bright spot in short axis, out of plane. You see the bright spot in the joint, but actually the tip of the needle can be out of it, the other side. So that's why I switch around on these ones into a long axis on the needle, but I place it in short axis. And if you're ever in that situation where and you're not doing the injection, so you're teaching them. But if you get people to line up on the AC joint, and you can either go straight in long in an in-plane technique, but if it's a tricky one, you place the needle in out of plane, and then you just switch the probe round onto the in-plane. And
okay, so let me just tell you this: there was an individual who taught up in Vancouver who used basically angles and distances in order to have his needle out a ways from his probe, and then he held it at a the 45-degree angle as he went down, and basically said if he started out 1 centimeter at a 45-degree angle, it is going to be then 1 centimeter down because of the Pythagorean or
Yep.
whatever else. Are
Yep.
you doing that, John? Are you doing like a 30 degrees and I'm a centimeter and a half away? That should allow me to come in at 1 centimeter, or are you right at your probe going down?
It depends where you're. Have a look. Sorry, I'm just getting to the wrong place. I'm trying to find injection. So I go injection there, and I'm trying to. For some reason, it's not seeing my sternoclavicular joint injections. Let's see. Because I have quite a few recorded, but I must be spelling it wrong or differently.
I see 2 to the top left, down about a third of the way. Right there.
Right, yeah, I'm just spelling it differently. Sternoclavicular joint injection. Yeah, these are. We're usually quite cautious about how you do these.
You're presently short axis. Oh no, I see.
That's going in long axis.
Yes, needle long, but you're short axis on the ace. Oh no, that's.
You see the blood vessels in the background. So these are the heart vessels, or heart vessels coming out of the heart. So you do need to see the needle on this one.
Good, man. I need to have help orienting. I don't know what vessel you're talking about.
Okay, this is the sternoclavicular joint.
Yes.
And so you got, I think, one of the ascending vessels out of the heart is coming up here.
Yes. What about that? So your needle is in line with the clavicle.
Yeah. So if the needle is, if we come back to here,
yes,
this is the short axis of the joint.
Yes.
So you place the needle in there, and then you look at it in the long section there, and you get this.
Posterior is on the right, anterior is on the left.
On the left is superior, essentially, yes. Superior and slightly more central. If I have a look here at AC joint, AC injection, let's have a look. Oh, get out of the way, bar. Why does it do that? Wait a second. Sorry,
It's all right.
I haven't got the hang of this Zoom malarkey. Moving the stuff around. AC joint injection. Yeah. So yes, so this is, if you imagine doing an AC joint injection and putting it in out of plane like I did the CMC joint, and then you turn the probe around and you see it come in here. So if you've got a big space like that, and then these fill up quite nicely. There.
What is filling up, John? Is there a capsule that surrounds it by connecting the A to C?
Okay. this is what an AC joint looks like in the sagittal plane.
Is the fiber like the material between the symphysis pubis, or is it hollow in the middle so you can fill it up?
There's a bit of both. It isn't a fibrous junction. It's a synovial joint. So there is space in there.
Yeah. Okay. So you're filling up a jelly donut.
Yeah. There you go. But there is also a sort of meniscus in there as well. So there is material there.
Look at that.
So that's what.
And what you did is just like you said on the CMC. You inserted short axis, or maybe you just inserted, and then you turned long axis
and then you
on
just
the
turn
needle.
long. Yeah. And so that's where for students wanting to practice out of plane and in plane and that thing, the AC joint is it's not always necessary to do that, but it's a very elegant way of doing it, and so that's when I get them to practice.
You come in superior, anterior.
It depends. I do almost all my shoulder bursal injections and AC joints with me standing behind the patient and they're sat in the chair. But if I think they're likely to pass out or a little bit vulnerable, then I will do it with them lying down, in which case I'm coming from the front. But it doesn't really matter. It's like you're throwing a hand grenade into a room. It doesn't matter which window it goes through.
Right. But one, they can see the needle coming at them with a little bit more clarity. The other one, you're behind.
Yeah, which is always, as long as they're not going to faint on you. That is definitely my preferred.
Well, I was a little concerned about that pulsing artery. Is that back and inferior?
Well, on this sternoclavicular joint, or on that last one.
Sternoclavicular joint. I understand now.
Yeah.
My mind had me out a acromioclavicular.
No, those were sternoclavicular.
And
joints.
I'm going, where in the world did you get a piece of plumbing that big?
Yes. Yeah. No, you would worry. That's where you'd need your Clarius thing. To say, whoa.
Well, you had to first have a brain, and then it wouldn't be a problem.
Well, there's always everyone has an off day. So let's have a look and see if there's anything interesting, because as always, there's just stuff turns up on my list all the time that is just interesting. This is a little bit of metal in a. Oh, that's going to annoy me. Can I move this? Yeah. Oh, that's right. I popped that out the way. Let's have a look. So this is a little bit of metal in someone's cheek.
What about that?
There's almost nothing to see. And the only reason I know it's metal is this patient walked into an MRI scanner, or tried to walk into an MRI scanner, and to have something completely different looked at, and discovered this bit of metal because he found himself being dragged towards the magnet by his face.
You're not telling me the truth, John. Is that a fact?
Yeah, well. So yeah, just a little foreign body there.
But you're telling me that the reason why it was even found was because his face was being pulled toward the magnet.
Yes, he told me everyone got a bit excited.
Unbelievable.
Yeah, it's this is. So I do struggle a bit with Morton's, and so this is me trying to assess this nerve as it's coming through here. You see the bursa here,
Yeah.
and just the slightly thickened nerve just above it.
Yeah.
There.
I think there are times when you seem to be long axis on the actual interdigital fairly well.
That's what I look for. You know, I'm never entirely sure what I'm looking at until I find the interdigital nerve. Yeah.
Yeah, you're amazing.
And let's look. Anything else? Yeah, you don't often see vascularity within the plantar fascia. And so with this patient who was quite, I was quite surprised to see how much blood flow there was in there.
Whoa.
And
you had actual vessel development within the fibers?
Yeah. Yeah, that was. This is another sternoclavicular joint that's just big and swollen, but it's not a great video of that one, so we won't linger there. Let me have a look. Distal injection. Yeah, this was a subtle one. There is not much to see on this, but it's one of those ones where you look at everything and then you just have to listen to the patient. So the reason you're not seeing anything of interest is because there's almost nothing to see here. This patient had atypical symptoms in their forearm, and they got out of a truck and the door had swung in the wind and just hit their forearm. But no black and white symptoms. I'm going to see if I can. I'm not even sure I've scanned this well enough for you to do it. Here I am, just here. This is the posterior interosseous nerve, but not where you normally see it going into supinator. These are the heads of supinator here, and this is the nerve coming out the other side. So having transited through, and all there is this bit of abnormal tissue just above it. And we decided in the end that it was scarring. So he'd bruised the nerve around there. And it
set up a fibrotic mass and,
yes.
and tethered the nerve,
yes.
attempting to irritate it.
So you can see that little black mark there. That's the nerve there.
Yeah. What about
coming out of
that? That's the arcade of Froche or something like that. Froche or something like that.
I can't remember. It's the far end of the supinator. So not where the nerve. We all look at it as it comes into supinator and looking for an impingement there. This was somewhere where it was sort of matted in with some scar tissue at the far end.
What about his symptoms? Were wrist and forearm or
yeah, wrist and forearm, and not very specific. He wasn't overly troubled by it by the time he came up on the list. So now we don't often see trochanteric bursitis without something else going on, but this is a bit of fluid just in the trochanteric bursa.
So point to the tendons, the gluteal tendons on that. Is that gluteus medius to the left?
There's probably some gluteus. This I think is gluteus minimus here. This is gluteus medius muscle, and gluteus minimus is there. It wasn't very obvious, so I didn't take a huge amount of video of it.
And the ITB is over the top of both.
Is over the top of it. That's the ITB there.
Yeah. Wow.
So I wasn't quite sure which plane that was in, but I took a little clip of it. Aspiration tendon sheaths. Now let's have a look. Incidental intramuscular. So yeah, I was just scanning along for something completely different, and I saw that.
What's that?
That is, I'm presuming looks like a lipoma, but some of the intramuscular lipomas are very, very fibrous.
Huh.
And which is why it is so bright, and it casts a dirty shadow over the
Wow, that's cool.
Yeah.
And this was so incidental they didn't even know it. I mean,
They didn't know it was there.
Do you
I've just-
sonopalpate? Do you push down on it? Do you just
Yeah.
move it around? And do you ever throw Doppler on, or because you don't see any type of coloration?
I would always throw Doppler, particularly on those, because the difference between that and a sarcoma are quite can be quite subtle. So yes, I definitely throw Doppler on that. Now the rest of those on that day were in ball injections. So let me have a look.
You know what I realized? I realized I need to do this more often, because you're not even getting close to running out of the cool stories you could tell me, John.
I do about sort of 3, 4, or 5 a day of stuff that's interesting on average.
This is rotator cuff?
Yeah.
Wow, that's nice. Tell me about that last little bit there. That's just don't you keep going. I keep asking you, but I'm fixated on the periosteal issues, and I think that it just happens.
It just happens, or it will mean something eventually to us, but we're not there yet. I think that was just a crazy day. I don't normally see a meralgia paresthetica injection from.
I want to see that.
But I did 3 on a single day. It was like all about.
This is short axis on the lateral inguinal ligament, correct?
It's close to it, yes. And there's the nerve there. And I'm just popping a little bit of local and steroid just around there.
What does that feel like to them when you're doing that?
The patient doesn't normally notice there. You can just see me sort of.
And is that because you put a local around it first?
Well, no. I just crack on with the injection. Let's have a look. There's another one. So again, this is a bit brighter. So I've gone in way too high there. So I bring it back and come down. That fascia is quite thick. So I just nudge the nerve then.
That medial to lateral?
Probably lateral to medial.
So that's not the ASIS on the right?
No, you're just in the soft tissue. But it won't be very far away. It'll only be a couple of centimeters south of that. I usually go.
How much are you putting in?
I usually put 0.5 ml to 20 milligrams of depamedrone and around 1 to 1.5 mils of 1% lidocaine. I usually use on these.
How many of you are doing this in the UK?
I don't know. There are a lot.
30?
Probably more than that, I would have thought.
On a given day, there's 30 of John Leddy's out there doing this kind of thing for the government.
I would have thought so. Maybe probably a lot more. That all the sports medicine guys are doing it.
And they're all physios?
No. There are in every hospital. There'll be a couple of radiologists that will do a list a week of this.
Well, how many physios like you are doing this in the UK?
I don't know. I really don't know. That somewhere I would have thought 30, 40, maybe 100.
My lad, I had no idea.
I have no idea. I might be.
I bet there's
way
2.
off it, but there are.
There could be 1.
Yeah, no, there's it's. I know some firms that will have 6 or 7 people working for them that do this sort of thing. So.
Wow. Too much, John. You've been generous. But your family's not there, so I can keep listening.
Well, you've got a better account than me, because when I go onto Zoom, it's nice if I'm doing a tutoring with one of my students, they get 40 minutes because that's all Zoom lets me have.
Oh, okay. Well,
and I don't want to pay for more
because you would like, but
no, I'm quite happy as I haven't got any troops here, so we can just if you fancy seeing some more stuff.
Yeah.
Label cyst. You don't often see labral cysts. I'd forgotten about that. So I'm just looking at the last week or so, so a couple of weeks. So just there's a little labral cyst in the hip.
Give me some anatomical reference
Oh yes.
above.
So if I better get hold of the thing then, because this actually was quite further lateral than you normally you're looking at the front of the hip. Well,
Yes,
these days I try to scan all the way around the hip joint, so front to back.
In the picture that's still right there, can you point just to that? The acetabulum is the bright thing on the bottom
acetabulum
left.
is here, labrum is here, capsule is here, and that's the hip there.
Yep. And that's the iliopsoas material over the top.
Probably yes.
Okay.
And then I'm kind of wandering around the side, and there's a little ganglion. And if I'd been worth my salt, or actually it's probably quite challenging to move around far enough because the depth would change if you followed the contour round, but you're just seeing the hip there.
Yes.
A ganglion there. So projection, you don't want to see that. Let's see.
You have a video of you injecting that, John?
What, the subtalar joint?
No, the labral cyst.
Oh, the ganglion. No, I won't have done anything about that. I can't remember the case actually, so I don't know why. But I wouldn't normally just go jabbing it if it wasn't indicated. If there wasn't a good reason to. I can't remember why we were looking at it at all. I think there might have been an MR that had mentioned it, so I will have gone looking for it.
I want to see that one.
Let's look. So that's a bit of rubble knocking around in the suprapatellar pouch.
How do you document that? I don't think you say rubble.
No, I think I said calcified bodies.
Okay.
Rubble's as good a word as any.
Yes, it is. John, how much dialogue are you having with the patients when you discover things like that? Labral cyst.
It depends on the setting. In radiology, if I'm scanning someone in a radiology setting, I try to be as helpful as I can. So I will say whatever I think will be useful to prepare them for what their doctor will say. But within the MSK services where I'm managing the patient, I'll just explain what I think is going on, and we'll discuss what to do about it. In much the same way you do with any primary care clinician. You know,
a consult with a plan of care.
Yeah. So that would be just what you do. I don't remember this. See, this thing, I see too much stuff because I've forgotten all these cases, and they're not from that long ago. So this is peroneus brevis here, just following it. So I can't remember. I can't remember what I saw, and then it's just disappears there. It's got the peroneus longus. Is that peroneus longus or brevis? It's gone. Yeah. So they're going over the ligament, and you come down, and there's where you pick it up again. Yeah.
Huh? Broke.
So peroneus brevis underneath. Yeah. And it just rocks on. I don't think I don't always get such a good long section view because it's curved. You know, it always looks like it's ruptured if you scan it badly, but it's disappeared at that point. And then you probably see why it's disappeared when you get all the way around here, because you sometimes get these very exaggerated notches with osteophytes on them.
Yeah. Just serrated knife cut it through.
Exactly that. This is just this very straightforward one, but it's just quite a good example of a very marked thickened cyst.
And that shows some of your thickened synovium.
Yeah.
Wow.
I don't know why I've taken a picture of this, because we see so many. I see a lot. Some that I have one list every fortnight that is sort of 50% ganglions. So I'm sick of the sight of them. But yeah, they're very common. I'm just trying to think where. Oh, at Greenwich. Any recent medial. So yeah, I don't really like calling medial sort of meniscal tears, because I don't think ultrasound's very good at it. But you see how the meniscus seems a bit short. I think it's just completely. So you've just got to, instead of getting a triangle, I've just got a square there.
Yeah.
Just lots of fluid at the back.
What do you think? A bucket handle has flipped the sucker around somewhere inside?
Yeah. Yes. That's all. Or some such unpleasantness.
Yeah.
So, and this is some synovitis around the APL, so the abductor pollicis longus. It's not the best video I ever took, but you can see there lots of synovitis there. I don't think that's quite so interesting to look at. Wristos. This was an osteophyte here, and that's impinging on the wrist. This patient couldn't extend their wrist, and they had some OA showing on the X-ray. But when you're trying to work out what that actually means to them in practice, that's the I think that's the I think it was osteate. I think that's on the scaphoid, or maybe the lunate. Can't tell from that image. I obviously didn't think to record it. And then this is it in.
Wow. That's a acute edge to it. Is it floating, or is it just
no, it looks like it should be, but it's static.
Wow.
Yeah, that's just on the edge of the wrist, on the radius. So it sticks up at a funny angle. I was trying to remember what that is. Yeah, so it looks there like it's a loose body, but actually when you go into the long axis, you'll see it's just this ridge that has risen up at the edge of the radius.
Wow.
Yeah. Anyway, I think we should probably call a halt there. But
John, thank you for your generosity in sharing, and I'm going to have to do this more regularly so I can exhaust you out of your backed up items, because this is very valuable to me, and I appreciate your time tonight, buddy.
That's all right. Well, that was just the last 2 or 3 weeks of interesting cases. So there's always so get in touch in 2 or 3 weeks' time and see the next lot.
I would like to do that.
No
I'll
worries.
probably have to jump over those, and I will tell you. I'll have to give you some feedback as to how my educational exposure has gone. It's always an up talking to you. Thanks, well, John. Tell your family hello.
I enjoy it, because I used to love doing those things when you go along and play scanners.
And think about the other stuff too that I was telling you about. I won't hold you to getting back to me, but if you do happen to have something, I know that I would love to. I would love to tap into your creativeness and see if I couldn't reward that. Anyway, take care, buddy.
Okay, thanks a lot. See you soon.
All right. Bye-bye.
Bye-bye.